Hello, and welcome to Strategic Perioperative Transformation, how Rush achieved 5% case volume growth and 8% increase in case minutes with surgeon-centric execution. On behalf of Lean Toss and Becker's Healthcare, thank you for joining us. Before we get started, I'd like to go over some housekeeping items. This session is being recorded and will be available after the event. If at any time you don't see your slides moving or have trouble with the audio, try refreshing your browser. You can also submit any technical questions into the Q&A box. You can also find a few other engagement tools on your dashboard. Please be sure to check out our resources section and fill out our event survey. At this time, it's now my pleasure to begin this session by introducing you to our first speaker, Rose Andron, who is the Director of Perioperative Services for Rush University Medical Center. Rose, thank you for being here, and the floor is yours.
Good morning, everyone. Thank you for joining us today. We're excited to take you through the story of transformation at Rush University Medical Center, how strategic execution focused on the needs of our surgeons led to measurable growth in volume, resource optimization, and sustainable cultural change in perioperative services. Our journey isn't just about numbers, it's about creating a data-driven environment where clinical excellence and operational excellence came together. My colleague is Sam Davis, Associate Vice President of Perioperative and Interventional Clinical Services. With over 15 years of perioperative leadership, he focuses on improving efficiency, performance metrics, and physician alignment across the surgical enterprise. I am Rose Andron, Director of Perioperative Services, and I bring over 18 years of experience in the perioperative space. I specialize in perioperative operations and data analytics. Here's the roadmap for today's discussion. We'll start by giving you some quick context on Rush University Medical Center. Then we'll review the historical challenges we faced, challenges that many of you may find very familiar. From there, we'll walk through the strategic steps we took, the results we achieved, and finally, what's next on our journey. We'll close with some key takeaways that you can apply to your own organizations. Driven by discovery, innovation, and deep responsibility for health of our communities, Rush is a national leader in outstanding patient care, education, research, community partnerships, and empowering a new generation of healthcare providers. Rush University Medical Center is a 671-bed magnet-designated academic medical center located on Chicago's West Side. We're proud to be ranked number 2 nationally by Vizient for quality, while performing more than 24,000 surgeries annually in our 37 ORs. Rush's reputation for excellence stems from our culture, one rooted in innovation, collaboration, accountability, respect, and excellence. These accolades are important because they reflect the broader ecosystem in which our surgical services operate. From Chime's recognition of our data analytics to CMS 5-star ratings and Leapfrog Group Safety Awards, excellence is an expectation at Rush. Maintaining these high standards means we cannot tolerate inefficiencies or suboptimal patient access in the OR, and that became a major driver for our transformation efforts. Despite our quality recognitions, gaining access to the OR was a significant challenge. We have 37 ORs, big to some, nothing to others, but either way, the OR was fully allocated, and by that I mean that every OR belonged to a surgeon or a surgical service. These blocks were considered real estate, and the real estate rarely left the hands of the original owner. Since there was no open real estate, there was no open time for new surgeons or for an existing surgeon to put on cases. We would find ourselves waiting until someone released their time, and these releases weren't often happening because there was no accountability, as no one was managing how one used their block. And how could we manage this block utilization when we didn't have the data to support any improvement initiatives? The inability to hold a block owner accountable meant this time was going unused. Even if we saw volumes going down in one surgical service and going up in another, we couldn't make any block decisions or changes. This led to complaints about imbalance in allocation across services. And thus a vicious cycle began, which I call scarcity mentality. There was no free time to start. No one could get additional time for additional cases. Since surgeons couldn't get time whenever they needed, no one would give up the time they did have just in case they needed it, and so on. This all contributed to difficulty in accessing OR time The unpredictability of block use and lack of releases created uncertainty about when cases could be added onto the schedule. Surgeons frequently voiced frustrations about unavailable time, and administrative leaders struggled to create equitable solutions. Without addressing access barriers, we realized that strategic growth would stall and surgeon satisfaction would erode. Data, or rather the lack of trusted, accessible data, was a major issue. Traditional methods like electronic health record reports and spreadsheets produced fragmented insights. Surgeons and staff often questioned the accuracy, leading to delays in decision-making and defensiveness. Without a clear, trusted data source, it was difficult to manage block time effectively or advocate for resource shifts. Adding to this complexity was the outdated block allocation method. Many blocks were historical artifacts, assigned years earlier and never revisited. Meanwhile, emerging services and new surgeons had little access. We recognized that if we didn't modernize and realign our allocation method, we would continue to underutilize our capacity. Our goals were ambitious but clear. Phase 1 focused on creating access, visibility, and data-driven culture. Phase 2 was about driving long-term strategic growth, using that foundation to expand services, optimize resources, and ultimately better serve our patients and providers. These high-level outcomes are the result of that strategic plan. Compared to fiscal year 21, we increased surgical volume by 5%, case minutes by 8%, and achieved a 12-time return on investment in fiscal year 24 alone. It's important to note that these numbers didn't happen by accident. They are the outcome of intentional culture change, operational discipline, and leadership alignment. Our roadmap targeted the biggest levers for change. Initially, improving OR access and a culture that valued data and data-driven decisions. Currently, our focus is on using that valued data to optimize the block schedule to meet the real-world demand and maximizing robotic platform utilization. When we talk about optimizing the block schedule with data-driven decisions, what are we talking about? The key metrics we use is volume, block utilization, and collectible time to paint a picture of overall block optimization. It's a connected set of data. Now, the traditional block utilization metric can be misleading. Two surgeons may both report 70% block use, but only one may have dozens of gaps that could be better utilized. By analyzing collectible time, we found a new surgeon-centric way to identify opportunities without penalizing performance. I always say block utilization is a good metric to show how well a surgeon participates or is an active member in the IQ community. They are releasing time, they're using their block. This all goes to block utilization. Collectible time, on the other hand, captures long, continuous portions of unused time, abandoned time, and release percentage beyond a certain threshold. This visualization highlights the opportunity hidden within those gaps I mentioned before. By focusing on collectible time, we could engage surgeons constructively, use objective, actionable data to have conversations about right-sizing blocks to actual need and demand. Collectible time considers only time that could have been used for additional cases and allows leadership to apply rules around release time. When we're fully blocked, growth only happens by reallocating underused time. Our surgeon-centric approach allowed us to preserve relationships while still making hard decisions about assigning time to service lines with pent-up demand. Right-sizing block allocation across the system allowed for increased accountability for unused block time, maintained fairness while unlocking capacity for growth, and provided more surgeon engagement and proactive management of OR time. With prescriptive analytics and predictive modeling, we moved from reactive crisis management to proactive planning. Instead of reacting to cancellations or bottlenecks, we could predict where opportunities would emerge and realign resources ahead of time. This is an example of a surgeon's scorecard used to determine if more time should be allocated or if we need to go back and optimize the time that surgeon already has. Finally, our resource optimization strategy extended to our robotic platform and other assets. We matched the right case to the right site, driving efficiencies not just in the OR, but across interventional and procedural areas. Every asset had to pull its weight. Using these tools, we were able to manage robots and the OR more efficiently, leverage tools and process change to drive the right case to the right place, and it gave us the ability to quickly adapt to strategic initiatives like construction, integration upgrades. We were able to accommodate more cases despite what was initially perceived as limitations. Okay, and I'll pause there and turn it over to Sam.
Thanks, Rose, for that presentation. Appreciate it. Transforming perioperative services required us to confront real-world constraints, staffing shortages, space limitations, and varying levels of buy-in from clinicians. Change management became a core competency, not just a support function. We knew that simply handing over data wasn't enough. We had to foster an environment where teams felt ownership over their solutions. That meant hosting cross-functional meetings, aligning KPIs to department-level goals, and acknowledging the fear that often accompanies change. This slide highlights one of the most critical factors to our success, creating a culture of cross-functional collaboration. Historically, OR scheduling decisions happened in silos. Surgeons wanted autonomy, schedulers needed clarity, and nursing leaders prioritized safety and staffing, but these priorities didn't always align. We broke these silos down by aligning everyone around shared performance metrics, such as block utilization, on-time starts, and access scheduling depots that were created in IQ. Through daily operation huddles and monthly check-ins with each surgical chair, we brought together clinical schedulers, OR schedulers, assistant unit directors, and surgical leadership. Shifting to a data-driven culture required more than tools. It meant changing daily habits and mindsets. We built trust by making data transparent, actionable, and a routine part of daily decision-making. Over time, teams moved from viewing data as punitive to seeing it as a powerful driver of operational success. With IQ, we provided a unified dashboard that all teams could access, ensuring that conversations were grounded in real-time data. This wasn't just about visibility, it was about building a common language and shared accountability. Each stakeholder had clarity on how their decisions impacted broader access and efficiency. This 5-step model became our blueprint for embedding data into the culture. From initial education to celebrating wins, each step reinforced that the idea that data is not just an IT project, it's a leadership tool. The result, greater transparency, faster decisions, and aligned goals across clinical and operational leaders. Transformation is not just about software, it's about partnership. We work closely with our partners at LeanTaaS to exchange best practices and tackle challenges together. This collaborative model positioned us not just as users, but as co-creators of solutions tailored to our complex needs. And looking at our results, this is one of the most compelling parts of our story. Since implementing our transformation strategy, we achieved a 5% increase in surgical case volume and an 8% increase in case minutes. Importantly, this growth occurred without adding new ORs or dramatically increasing staffing. It was purely the result of smarter utilization. This validated that we had significant latent capacity that could be unlocked simply by improving access and efficiency. Another key metric, prime time utilization. Prime time are those critical morning and early afternoon hours. It is the most valuable part of our OR day. By improving scheduling practices, surgeon engagement, and first case on-time starts, we increased prime time utilization by 3%. Even a modest improvement here translates into significant surgical revenue annually and improves the experience for both staff and patients. Block utilization rose by 9%, which represents a significant operational win. This success stems from our work on transparency and accountability. And by providing surgeons real-time visibility into our block usage, along with proactive recommendations on how to optimize or release unused time, we created an environment where surgeons took greater ownership over their schedules. The financial impact of our work cannot be overstated. In FY24 alone, our transformation generated a 12 times return on investment. Year over year, we saw strong and growing returns. This sustained financial performance demonstrates that operational excellence isn't just about cutting costs. It's about building resilient team systems that drive clinical, financial, and patient access outcomes simultaneously. Summarizing the results, across volume, minutes, utilization, and financial performance, we've not only achieved growth, but created a sustainable platform for continuous improvement. These gains were not one-time improvements. The cultural, technological, and operational structures we put in place are designed to evolve with the organization and support ongoing strategic goals. Looking at our current initiatives and our next steps, looking forward, we are not resting on our success. Our roadmap continues to evolve. Current initiatives focus on expanding optimization into procedural areas like interventional radiology and endoscopy, and tackling one of the most complex areas, staffing workflows. We know that to remain competitive and sustainable, we must continue to push the envelope on operational performance. One of the exciting innovations we've embraced is AskIQ. Leaders across our organization, like Dave at Rush Oak Park, are now using AI-powered tools to obtain answers to operational questions in seconds. Whether it's block release rates, utilization trends, or forecasting, what once took hours now takes only minutes. This dramatically accelerates decision-making and frees up leaders to focus on proactive management. We also recognize that optimization efforts couldn't stop at the OR. Procedural areas like interventional radiology and endoscopy represent significant volumes and financial opportunity. Historically, these areas operated as black boxes with little transparency into performance. We're applying the same principles of access, accountability, and optimization to these procedural environments to drive system-wide improvement. Optimizing procedural rooms is not just about uncovering hidden problems. It's about proactively managing them like high-performing clinical assets. By having direct access to real-time performance metrics, we can make smarter decisions about case scheduling, staffing needs, and equipment utilization. Procedural areas deserve the same strategic oversight we apply in the OR, ensuring that every room, every schedule, and every resource is working at its highest potential. Staffing remains one of the greatest challenges across healthcare today, and perioperative services are no exception. Historically, staffing workflows have been highly manual, reactive, and inefficient. The result? Staffing shortages increase overtime, frustration, and burnout. We recognize that unless we modernize staffing, which is forecasting, scheduling, and skill alignment, we would continue to struggle with both clinical quality and staff retention. Looking ahead, one major opportunity for Rush is modernizing staffing workflows using predictive analytics. This platform forecasts surgical demand and staffing needs with over 90% accuracy, allowing proactive case-specific staffing. The tool represents an exciting next step to further optimize efficiency and improve staff experience. Investing in predictive staffing will be critical for sustaining and accelerating our perioperative gains. To summarize our journey today, there are three critical takeaways. Number one, interdisciplinary collaboration is essential. No single department can optimize perioperative services alone. It requires alignment from surgeons, nursing, scheduling, finance, and executive leadership. Number two, let data drive decisions, not emotion. Transparent, trusted data removes defensiveness and enables productive conversations and accountability. And last but not least, number three, continuous learning and adaptation are critical for sustainability. Transformation is not a one-time project. It's a mindset that must be nurtured and evolved as challenges change. These principles have been and will continue to be the foundation of Rush's perioperative success. Thank you for allowing us to share our journey with you. We are incredibly proud of the work our teams have accomplished, and we hope our lessons learned can offer insights or inspiration for your own transformational efforts. Thanks again.
Thank you, everyone, for joining us today. We appreciate your engagement during this session. I'd like to thank our speakers, Rose and Sam, for taking the time to chat with us. As a reminder, please check out the resources section in your console and complete the survey. Have a wonderful day.